Welcome, everyone. Thank you so much for joining us to the Academy of Biomimetic Dentistry webinar series. We're so glad that you could carve out the time to be with us today. Thank you very much. As most of you know, today's featured presenter is Dr. Grant Chyz presenting to us. We are so lucky and honored to have him here today and looking forward to just an awesome presentation. My name is Carla Marshall. I am the Executive Director for the Academy of Biomimetic Dentistry. I'd like to introduce the board members for the Academy of Biomimetic Dentistry. Dr. Mark Lazar, our president. Dr. Saul Pressner, our president-elect. Dr. Teresa Monzon, our vendor liaison. Dr. Joseph Sutton, secretary. Dr. Michael Haney, treasurer. Dr. Diane Caprio, scientific affairs. Dr. Paul O'Malley of membership. Dr. Jim Erpenbach, board member. Dr. Melissa Siebert, board member. Dr. Charles Rupenack, board member. Dr. Jay Resnick, board member. Thank you so much to all of the board members that are on the call today, and a special thanks to all of our scientific advisors that are on the call as well. Glad to have you all here. You're in for a real treat. This is a two-part series. Today we will learn about a new paradigm for direct restorative dentistry. And please mark your calendars, just in 2 weeks. Saturday, March 27th, Dr. Grant will also be doing his second part of his presentation, Advanced Perspectives on the Use of Continuous Fiber Reinforced Composites. Today, we are offering CE for those of you that registered for CE. Thank you so very much. We will take care of that. We will ask that you stay from the beginning to the end of the entire webinar to qualify for your CE. I will post a code towards the end that you will need to add to your certificate to get that CE. Our CE is provided by Dr. Melissa Siebert and the Dental Digest. If you haven't already, please make sure that you like the Dental Digest podcast. Super awesome podcast hosted by our very own board member, Dr. Melissa Siebert. So check that out if you haven't already. Like her on Instagram, it's awesome. We will also be doing some polling questions. The polling question will be at the beginning and at the end. We ask that if you have CE, that you also do those polling questions. That's how we know you were here and that we were able to teach you some things on the webinar today. So once we get everything calculated, in the next few days, you will receive an email from Dental Digest. That is how you will be able to go in and claim your CE. So please watch out for that email. That's how you can claim your CE. And I think I've got that down. I would like to introduce the president of the Academy of Biomimetic Dentistry, Dr. Mark Lazar. Here he will introduce today's feature presenter. Thank you so much.
All right, thanks, Carla. Well, we have a great group of people here today. This is amazing, from all around the world. So I would love to take the distinct pleasure of introducing Dr. Grant Chyz. Dr. Chyz has graduated from the University of Michigan with 30 years of clinical experience under his belt, plus the 30 plus years. And he's also part of the faculty at the University of Washington. Grant is a renowned lecturer. So you guys know he's been lectured extensively and has extensive experience studying and working with laminated fiber reinforcement. Now I've had the privilege of getting to know Grant pretty well over the last few years, and it's actually through one of our conversations over this past summer that the idea for going virtual and hosting all these webinars came about. So we have that conversation with Dr. Chyz to thank for a lot of this that's going on right now. Grant has been a great friend and a mentor to us here at the Academy of Biomimetic Dentistry. And it's for this reason that we have awarded him an honorary fellowship into the ABD. And we've also invited him to become our newest member of the distinguished group of scientific advisors for the Academy. So without further ado, I'd like to turn this webinar over to Dr. Grant Chyz.
Hello, everybody. All right. So we have a roadmap for today, and I'm going to start. We're going to be starting with some groundwork. Some of you have heard me speak about fiber from previous ABD meeting. Some of you have not. So I'm going to try to lay the groundwork for our treatment of cracks, our treatment of tooth structure, and why I think fiber can play a role in changing the way we think about our restorations. So the first part of this presentation is literature, and it's not a lot of it, but it's enough to get us all on the same page. Then we're going to look at new information about prepping out cracks as we work our way through one fairly complex case. So we're going to go through a case that was in the promo piece in detail, step by step, and looking at how certain principles apply to each step, which is really important. And then finally, we'll talk about what I like to call the elephant in the room, which none of us talk about very much. And it might be interesting afterwards to see what other thoughts exist. So when we finish, there will be a little piece by Carla or Matthew, and then we will answer questions. I'll stay to answer whatever questions you have. All right. So I have one disclosure, and I'm an unpaid consultant to Ribond. David Rudo has become a very good friend of mine, and this started through interest about a patient and has continued to this day. He introduced me to Alireza Sadir, who's also become a very good friend. We've done research together, and Ali is why I'm at the University of Washington. So I owe a lot to David. I've never received anything from him financially, but we are friends. This is downtown Seattle on the right, and my house is right over here near Volunteer Park. My office is downtown. University of Washington is over the Arc, and that's my dental world right there. Home to work is less than 10 minutes on a good day, an hour pre-COVID in a bad day, because traffic was terrible. So as we move downtown, my building was built, the building I'm in was built in the 1920s and then added. Half of it was built in the 1920s, the half on the right. The half on the left was added in the 50s. And we have right now 40 dental offices in the building, physicians, chiropractor, massage, some other things. 40 offices, I'm not sure exactly how many dentists. And this is pre-COVID. We don't have magazines out anymore. We have plants there, but a pre-COVID view of my front desk. And then I have 4 operatories, 2 are hygiene, 2 are for me. And we have ADEC units in the rooms, air abrasion with AquaCare. And I'm not doing any milling or scanning, so I'm still analog with impressions. Oh, also, this is important. So I'm an out-of-network dentist, and we have a world group of people here. How insurance works is different in different countries. In my case, I'm not in network, which means I don't, I'm not a participating provider, but we have patients who have insurance. We process that for them. We ask them to pay the estimated difference, but I'm not controlled in my fees or in my procedures by the insurance companies. And so that seems like a easy thing and a wonderful thing to do. It has its benefits. It also has its disadvantages. I have to build value with my patients every day because the insurance companies try to say, you shouldn't go here, you should go in network, it'll be cheaper. So that's something that we deal with. Okay, so one of the questions on our little promo thing is direct versus indirect. And this is not about so much direct versus indirect, but I'm going to address that right away because I do direct every day. Not every day, but I do direct. Well, I do direct every day. I do indirect when I need to. I prefer direct. But in a full mouth case with terrible breakdown, I'm going to do crowns and implants and bridges, and they're going to be done with a biomimetic influence, with adhesion, with excellent control of variables. But I still do crowns. I mostly only if they've had them or if they're periopros case like this. And I don't feel there's a way to manage that predictably as single teeth. In this case, there's an implant, 2 crowns, veneers, crown lengthening. Again, the veneers are minimally invasive. The existing crowns are crowns. And so we do traditional work with that. And then obviously a crown is a crown. So once it's a crown, it's kind of always a crown. And whether it's that or this in the lower right, which I'll be addressing a bit more directly, not at all today, but in the next presentation, which is what do we do when there's nothing? And there are some things we can do. We have some good data to support that. So we see this every day in all of our offices. We see failures. And they're not our failures necessarily. They could be. Some of them are, some of them aren't. But most of the failures we see, if they're not just pure decay, started maybe with decay because then we did restorations. But in the end, teeth break down. And that's where we want to try to move the dial and reduce the breakdown. So we're going to start by talking a little bit about perceptions around the world. This is in Kuwait. So we're going to be looking at a study quickly from Kuwait. And it's very interesting. There's confusion about cracks. There's confusion about loss of tooth structure, or there's just different perspectives based on your experience. We all have, I don't know why there's some painting on my screen. Is that on your screen, Carla?
No, nothing. It's just,
Okay.
oh, the little paint, the yellow at the top.
Yeah.
Yeah, that's on ours.
Where in the world did that come from?
Just a little art for all of us.
Okay, I guess so. I don't know. I'm not going to try to fix that right now. Some reason it's almost like someone else has got their finger on their screens and it's painting on my.
I see it. I'll see if I can fix that. I'll see that.
Okay. All right. Anyway, so we have a scenario. There's 5 scenarios here. This one, vertical crack in a premolar, no separation of the segments. The patient was asymptomatic and tooth was vital. And this is 32 prosthodontists, 34 endodontists, 29 general dentists. 2/3 of the specialists were US trained. And the breakdown is kind of no directs, some no treatment, indirect restorations is C. So that's over here. I think I'm getting really distracted by these marks. Are they showing up for everyone? Anyway.
Yes, I'm going to try to turn that off right now. I don't know how it's happening, but I'll try to get rid of it for you,
I've
Grant.
never seen that happen before. So again, quite a lot of, so asymptomatic tooth, vital and minimally restored. Still, the majority of people are going to do indirect. Some are going to do a root canal, don't know why. And extract for some, it's bizarre. So we go to the next scenario, vertical crack evident, no separation of segments, irreversible pulpitis. Here, pretty much agreement. Everyone's going to do a root canal and almost everyone's going to do a crown. That's probably the norm. Vital tooth, cracked across most of the pulpal floor. And here we have a smattering all the way across. Extract. No one's going to do no treatment, direct, indirect. Not a lot of agreement. There's not a consensus showing up here. And the same thing here where we have a vital tooth with a broken off cusp, an amalgam, and radiographic changes. And 40% of the dentists there would extract that tooth, which is interesting. This was a study by the National Practice-Based Dental Research Network, which is a researcher monitored and coordinated effort of private practices. So it's private practice dentists participating in research. And there's, I think, five spots around the country. And these were the pictures. So they were given these scenarios and asked what they would do. And the question was just, are you very likely, not likely, or definitely likely to crown? And in this first case, most people were not going to crown. We go to the second one, however, and again, a lot of crowns being recommended, half. More or less half are going to crown. And then we go to the third, to C, and it's again, heavily 2/3 crowns. and we go to D, and it's interesting, 3% are not likely to crown. I'm guessing maybe they were likely to extract, but who knows? Anyway, there's disagreement, and there's so different positions, different beliefs, depending on where we were trained, depending on our experience, depending on our lives, depending on our practices. I know for my practice, cracks kind of rule the problem, the most common problem. And for Dr. Satter at the UW, it's decay.
Okay.
It took forever.
Can you please mute if you're on? Thank you. Go ahead, Grant. Sorry.
It's all right. You know, I'm going to close this and reopen it, if you don't mind, to see if the pen disappears.
Okay,
I'll go right back to it. I'm sorry.
we're back. Thank you,
Okay.
Grant.
All right, so we go from this crack thing and we say, how do we decide about whether we're going to treat a tooth or not? How do we decide what's going to happen? And most of the time over the past, it's been symptoms. So we look at these 3 teeth and we say, well, what would we do here? And when I've done this with study clubs, I've probably only done it 3 times. So maybe 60 people, and 5 people have said it depends. It depends what's inside. Otherwise, people are pretty quick to either say we're going to crown it or we're going to do a new composite, making decisions without thinking about the relevance of those cracks. So when we look at the teeth inside, we see actually on the left, we see actually buccal and lingual cracks. Crack cusps, those are oblique cracks. And we see a vertical crack in the middle tooth. And then on the right, we see marginal ridge cracks. The middle tooth has it was cleaned up a bit, still a crack. And I lost track of this one. I don't actually know what patient this is, but I would have recommended back when this picture was taken a crown. The one on the left, I would have recommended a crown. And in fact, I did that. I'm not ashamed to say it. Given what I knew, given then it was like 20 some years ago, that's what I did. The tooth on the right has marginal ridge cracks that do not extend into the pulpal floor. And so back in 2010, I wrote an article for Inside Dentistry, just a trade journal article called Treating an At-Risk Tooth. And the question was, do you look at this situation and decide to treat? Do you take that as an indication? If there was no sign of decay, but there were, let's say, stained marginal ridge cracks, would that be relevant to you? And is it worth treating? And my argument has been that those are often signs of extension into the tooth, into the dentin. So in this case, I cut out the cracks, then there's no cracks, which is the best cracks of all, none. I rebuilt the proximal and I put Ribond inside the tooth. You can't see it here because when you wet Ribond and do all your stuff, it kind of disappears. So I simulated that with Photoshop. I took a piece and kind of stuck it in there to show what was going on, and then finished. And back then in 2010, I noted in the article that if the tooth had had this, I would have recommended a crown. Today, that's not true. Cameron did the original cracked tooth syndrome kind of nomenclature. We're not going to delve into this, but he noticed that the problem is early diagnosis. And today, not so much if we have loops and magnification. I use either 4.5 or 6 power. I know Pascal says you got to have 8, but I use magnification and lights. And he said that it was assumed that cracks had not progressed, but they had all penetrated into dentin. So the question really isn't enamel, it's what's happening in the dentin. 10 years later, he went on and 25% of the teeth require root canals. He decided treatment to prevent further cracking is a must and advocated full coverage. In this study done in 2019, 31,000 teeth. It's a 2.7-year study, not long enough, but wide range of variables influence survival of teeth. So we had caries and fractures, and then endodontic treatment. And I would argue endodontic treatment is generally necessary because of caries or cracks. And fractures might be a different category where the tooth is gone or part of the tooth is gone. So there was a wide variety of failure rates for different dentists. We have different perspectives, different situations in our offices, different skill sets, different materials, not surprising. Individual patient variables are not surprising. Some people just break everything. Some people have caries problems. Some people have periodontal mobility, all kinds of different problems. And that obviously affects outcomes. And then, but with all of that, restorations placed due to fractures or cracks were the most likely to fail, even more so than caries. And for 2.7 years, honestly, that surprised me because that's not a very long observation period. So then we move on to another, this is the last one of these. So we had 39 potential risk factors for posterior tooth fracture. And this is fracture. So presence of an enamel fracture line, this would be external, was correlated to a 75-fold increase in the risk of fracture. And the volume of the restoration also was a strong variable related to the risk of fracture. And that's also not surprising. Anyone who's been practicing dentistry prior to, let's call it the adhesive era of dentistry, so maybe, let's say at least 25 years back, knows that depending on where you went to school, a third to 2/3 of the intercuspal width, you're going to recommend full coverage because those teeth would break later. And we said that because we had no adhesion and they would break. The studies supported that. All the studies supported that. That in the long run, once a tooth has a big restoration, we need to crown it. Unfortunately, that custom has persisted into the more modern era of adhesion. And other factors also play a role. So back in 2011, I was preparing to do a talk at the American Dental Association on asymptomatic incomplete cracks. It was my first talk, well, it's my only talk at the ADA. And at least one of the instigators of that talk is in the room here with us today. That's Mark Freeman, who is an endodontist who has been looking for the diagnosis. Why does the tooth need endo for a long time? And I had been tracking cracks for a long time. So in August, just before the October meeting, this study came out from Dwayne Arola, who was then at University of Maryland. And it was like a light bulb went off. Properties of dentin vary significantly based on age and depth. This is written in a funny way, but it basically says the deeper you are in dentin, the more easily dentin cracks or propagates a crack. The closer you are to the optical DEJ, to peripheral dentin, the more resistant the dentin is to cracking. 1,000-time difference between the peripheral dentin and the deep dentin. In addition, as you get older, as people get older, the teeth become less resistant to breaking and cracking. And deeper a restoration is, the closer, the further it is into the dentin, less crack resistant dentin. So deeper dentin restorations are more likely to crack, not only because of the leverage and the factors involved with occlusal forces, but because the dentin is not as crack resistant down there. This is, so Dwayne Arola came to University of Washington and actually last Friday, he and I talked for the first time about cracks, about crack length and some other issues. And he is a mechanical engineer affiliated with dental school, but he's a mechanical engineer. And he has written so many pieces about tooth structure, fracture, fatigue, and what happens to teeth that it's amazing. Most of his stuff I can't understand because it's full of equations and it's a kind of an academic thing, but there's always the sort of core points and they're very worthwhile pieces. And so in the last 10 or 15 years, prior to that, everything was mechanical. But in the last 10 or 15 years, the importance of fatigue has come into vogue, so to speak. And what's been recognized is that everything we do weakens teeth, everything. And that starts to kind of play with you a little bit. For me, it's been everything I do looked at from the perspective of how it may or may not affect propagating or starting a crack in a tooth. So everything we do makes things weaker. Fatigue should be a central concern in the development of our materials and in the geometry and the placement of restorations. But fatigue studies don't happen very much because they take forever. We did Dr. Shatter, and with my help a little bit, did an endo core study 4 years ago. The longest running sample was 5.5 million cycles. It took forever to do, and those are really difficult. So the tendency is to run a few cycles and then load to fail, which doesn't work as well. So this last bullet point is really related to an area that Ali Satter is expert at. He'll be speaking, I believe he's currently scheduled for June for the ABD webinars. It's a can't miss thing. He's brilliant, and he uses optical coherence tomography to actually look at that interface in a way that Dwayne couldn't. They use sectioning methods. Ali looks at it on OCT, and sometime in the next week, I'm going to send that little paragraph to Dwayne with some copies of Ali's OCT. Pretty interesting. So he'll speak more to that, but let's put it this way. Everything we bond, almost everything we bond is imperfect. The bond interface, especially if we do one step in bulk fill restorations or fillings, the bond interface is flawed and has delaminations. The best we've done is with fiber. And the second best product has been this Bulk Easy product. But basically, there's always defects. That means leakage, it means structural effects. So that's kind of hard to swallow. All right, so sort of summary of some structural considerations here. Cracks in enamel, they're not important unless they go into dentin. If they are in dentin, they're very important, because if they're in dentin, they almost certainly will grow. There are some academic exceptions, but essentially, once a crack gets started in a dentin, presume that it's going to go. It's either going to go vertically or horizontally or obliquely, but it will grow. Watching a crack in dentin doesn't make sense, although we can't always remove them. So we'll talk about that in a bit. Dentin is toughest superficially, so early identification and management of cracks in dentin can lead to more successful outcomes. Oh, sorry, I'm going to pause for a second. I have a lot of this written out because if you want to take screenshot photos of the computer, I am fine with that as long as you're not circulating it, social media. If you're using it for your own information, I'm fine with you doing that. I put a lot of things in text so that you can gather that information and look at it later. This presentation will also be available for a limited time on tape. So sorry for that interruption. All right. Flawed or cracked dentin is weak. And there's all kinds of variables that contribute to this. So as we learn more about how our actions affect dentin, we want to try to refine our techniques to be less bad. We can't work on dentin with no effect. The question is, how can we minimize the negatives so that we can maximize what we can do restoratively with the positives? Subcritical cracks, which is a hearing term, may generally be asymptomatic, but once they reach a critical length, failure is inevitable. That's when it goes. And so waiting for symptoms is too long. In my experience, if I'm treating a symptomatic cracked tooth, my odds of successfully managing that are diminished. They're uncertain. If I find cracks that are in the teeth without symptoms, if you please, yeah, thank you. The fatigue failure behavior of dentin with crack extension, of course, can result in all these things: broken tooth, broken cusp, split tooth, lost tooth, pulpal degradation. And if we have pulpal degradation because of a crack and the crack extends, then we're going to later have tooth loss. So our periodontists see cracked roots with crown teeth I got to tell you, those teeth had cracks before the crown was done, much of the time not identified. So identifying where cracks are, whether you can get them out or not, helps in determining the prognosis, and it helps later on understand what's happening. So this slide I originally built in, it's a GIF in relation to Graham Milichich's Poisson effect, and it's kind of demonstrating that, but it's also demonstrating occlusal forces, wedging forces. If I had the little deal hitting it here obliquely, it would still be creating those forces. And so as we get as we and our teeth get old, they become brittle, and stresses grow and fatigue starts in. And if we get the beginning of a crack, it will grow. So all of these things can negatively affect the strength, integrity of our tooth. And so we try to manage what we can. We try to recognize it and manage those variables within our control, within our wheelhouse, and try to do the best we can, because we want to limit this. We'd like the teeth that we restore, we'd like to not have to restore a tooth. If we have to restore it, we'd like to do it in such a way that it doesn't create collateral damage over time. At least for me, that's so important. This is from a study that Pascal Mann published in 2016. And what's interesting here, these are like big studies looking at failure rates and average annual failure rates. And other than that glass ionomer cement line, he views them all as statistically similar, not different. So the justification for one restoration or the other in a large population, he claims and says, is really just not justifiable. Now, each of you, everyone watching today, is going to say, but in my hands, this works better, and in my hands, this works better. And you're right, in your hands, you see differences in results. And so this is applied broadly. But when we do apply it broadly, we start to look at some variables here. And I love this first line. For too long, the longevity, the restoration itself has been the focus of attention. And I've had discussions with a few people over the years about amalgam studies. So amalgams are great. They're inexpensive. They last a really long time. All the studies say that. And in this one particular discussion I was having with a dental school person, I said, I think all the studies are wrong. And he looked at me like I was an idiot, and he said, well, what do you mean? And I said, well, the studies look at the life of the restoration. They don't look at the life of the tooth, which hopefully corresponds to the life of the patient. And he kind of stopped for a minute. He goes, I got to think about that. So today, it's more important to preserve the tooth than the filling. The filling is no good without the tooth, and the tooth is no good without the patient. So this becomes a different perspective. What is the damage caused by that amalgam after the amalgam wears out or needs to be replaced 30 or 40 years later? What comes next? And what comes next is often a crown, sometimes a split tooth. So there we go. Now, all of this stuff that I'm talking about, it's only going to make sense with modern adhesive materials placed meticulously. If they're not placed well, they don't work. So bonding with contamination doesn't work. But if we're doing our adhesive restorative procedures properly and carefully, and we're managing the materials, then things start to change. So longevity data are no longer a justification for making a choice between direct and indirect, between resin, composite, metal, or ceramic. And I know Junji Tagami, who's speaking next month, he's a composite guy. He's brilliant. He's been using composite forever. And he showed a slide once a couple of years ago that I saw, and it struck me. It was like the composite was not pretty. The tooth was worn. The other teeth in the dentition were also worn. I think it was a 30-year-old composite. And I thought, my gosh, if that had been ceramic, the other teeth would be pummeled and that would still be there, or it would have broken. So in a way, composite is extraordinarily biomimetic, especially newer composites that wear well. So then it depends on your wheelhouse and what your skill set is. So today with adhesion, fiber, and biomimetic principles, that creates enhanced opportunities for preserving tooth. And these are, just some things that I've done. That's direct and direct. This is one of my favorite teeth that I've ever done because it just turned out pretty cool. This is with fiber. This is something we'll get to in the next seminar, but it's, virtually no ferrule. And yet I got rid of the post and did a special type of fiber reinforced core and a new crown. All right, here's our tooth. So before we start treating it, let's think about our diagnosis. One of the fathers of periopros, Mort Amsterdam, used to say there may be different ways of treating disease, but there can only be one correct diagnosis. And so getting a good diagnosis is always important. And here's what I can come up with this tooth. Recurrent decay, failed margins. There's a mesial marginal ridge crack. There's actually two of them. This could be a crack or a craze line. There's a craze line here. And if we look closely, if we put a light on this tooth, there's other craze lines. Do they go into dentin? Don't know. Buccal cusp has microfractured enamel. Some of this would be the Graham-Millich's occlusal rim fractures. We have a vital pulp, and there's no symptoms. So what are we going to do? I've asked this of some study clubs, and most everyone says crown to buildup, which is not unreasonable by most standards. So my treatment plan, though, is carefully remove the old amalgam and the decay, and then evaluate the structural integrity of the tooth. And from there, I don't know, the tooth decides. It's kind of a cheeky way of saying the condition of the tooth dictates where we can go. When this is happening, the patient has made the appointment. So we're talking about doing this. And we talk about the fact that they might need a crown, a root canal, and a buildup. Or if the tooth is cracked across the middle of the floor, they could even lose their tooth. The fact that they don't have symptoms, that this person didn't have symptoms, was a huge positive. It meant there's a better chance than not that we could manage what we find. And so that's what I tell people. And this case, first of all, I think it's a really good case for a kind of a comprehensive example, but it's also one I did in 2015. So two things that I do now are different, but otherwise it's all the same. I'll tell you what those are. And and I have an x-ray from 2021. It's done fine. So it's got 6 years under it. So this is not like, I did this yesterday and it's really cool. I did it 6 years ago and it's still working beautifully. So that's important. So when we're dealing with removing amalgam, years ago, I switched to electrics because no vibration, they're most concentric. And so I use electric handpieces. I use 1157s are my go-to remove an amalgam burr. Basic, not for micro preps and little preps. I use a lot of little things, but for a basic like filling replacement, I'm either going to use an 1157 or a diamond that's shaped about like that, and which is that 838 style diamond. And I do that with a very, very, very light touch. I noticed recently I got this little epiphany. It was kind of weird. I've noticed that on amalgams, and if you think about this, or if you haven't, pay attention to this. When you take some of them out, some of them have a grain. I think the lathe cut amalgams, the old lathe cut amalgams have grain and they grab your burr like gold will. So they'll create chattering. The spherical amalgams, I was taught Titan. I don't do amalgam. I have it for at least 25 years, but I was raised on Titan amalgam, which is spherical, and it cuts like butter. It cuts smooth. And when I take out amalgams, if they're smooth, I think there are fewer cracks. I don't have a study on this. And I know that back in the early days when I didn't have much magnification and I didn't know about cracks and I didn't know these things, there would be times where I do remove an old amalgam because it needs to be replaced and do my work. The next day, the patient has discomfort. And I think the most reasons for patients coming to my practice, leaving a dentist and coming to my office, is because they say something like this: I had a tooth that felt fine. The dentist told me it needed to be replaced. He or she replaced it, and now then it hurt, and now it has a crown and a root canal, and it still doesn't feel right. And you can say from that it was cracked, it just wasn't noticed. So it pays to look, and it pays to inform our patients ahead of time. CR research did a thing about burrs with crosscuts or non-rounded shapes, increasing the risk of damage. I never, ever use, I don't have any square edged, sharp edged, flat top burrs. And I don't use crosscut burrs at all. But it actually goes further than that. And we're going to see that here. Daniel Hovender, one of Ali Sadira's dental students, I believe second year dental student, this summer got involved in a study that Ali and I cooked up, which was to put cracks in extracted teeth. And we had to work a lot of different ways to figure out how to get the crack in there. We tried ultrasonic knife, which basically created all kinds of damage, which makes me wonder about ultrasonics. We ended up using a very fine diamond disc. And then Daniel used a variety of rotary instruments, 1156, I think, a round carbide, a round steel burr. And then I lent them one of my AquaCare units, which they used with 53 micron aluminum oxide. And so the deal was place the cracks in the teeth. Dr. Satter with his OCT could scan the teeth and see where the cracks were, measure them, and then Daniel worked to prep them out. And then the question was going to be what happens after that. We've been told, certainly in the biomimetic world, that you can prep out cracks within certain measurements. And I think you can, but according to this study, according to what Daniel found in his hands doing the prepping, the burrs all propagated cracks. Some created collateral cracks, branched cracks. Some, it wasn't consistent, but some created deeper cracks. The only thing that didn't propagate cracks was the air abrasion. And so if I'm doing pulpal floor cracks after that study, I'm just, it's AquaCare. And there are some conflicting information. There's conflicting information about air abrasion and bond as I've delved into the literature. And so the air-based, which is like the Crystal Mark's a great unit, and they've been great supporters of biomimetic dentistry. I'm curious about air effect on dentin and the hybrid layer, where the AquaCare and I believe the Prep Start is got water-based. AquaCare in countries other than the US, they're using a solution that improves the effectiveness. In the US, we're stuck using distilled water for the time being. And they have a whole bunch of powders. And the tip, there's no clogging, but the tip is kind of big, and it works. It works very nicely to clean preps as well with the immediate dentin sealing concept. So we're going to move on. We've got the amalgam out. Use electric handpiece, 1157 burr. Very, very, very light touch. I wonder on those teeth that chatter, or if you're aggressive, how often early cracks or damage that are already in the tooth propagate because of that vibration. And that's a concern for sure. So we clean that out. And when appropriate, I use caries detector dye and then look closely. And so when we look at this tooth, now I've, excuse me here. So we've gone there, and then I'm going to use an 1158 on the line angle. So I want the line angles to be round, and then, dentin and old amalgams especially, there's often notches, sharp line angles, they got to be round. So I use the 1158, or the diamond, which is 1.2 millimeters. I'd like to use the AquaCare, but I have difficulty controlling the shape with the AquaCare, so I'm working on that. But right now, I clean the tooth with AquaCare after. I use AquaCare on pulpal floor cracks and no burr there. And then just try to be very light and gentle. So we get this cleaned out and there's no cusp cracks. We've removed anything there. And we go on and we see that the mesial lingual marginal ridge crack goes through the tooth into the inside, but it doesn't go onto the pulpal floor, the prep floor. So that's great. And in this situation, I find that I'm a little inconsistent. I cut it out, depending on how it looks, or sometimes I'll thin it. And I think it's better to get rid of it because the tip of the crack can still grow. In this case, I prep it out. And this other crack, which is up here, that didn't go inside. And so that's a crazed line. That doesn't matter. I'm not going to cut that away. I get rid of the microfractured cusp enamel with a 30 micron diamond. And then we move on. So this is where on that crack on the wall, I would have used AquaCare on that today, where I used a burr then. And I used the AquaCare and I might use a diamond to just clean it up a little, do a little bit of a bevel outside and seal, but AquaCare on the pulpal floor. So we get to this point and then we got to say, all right, well, kind of what's next? And this study done by Edelhoff and Sorensen in 2002, it was published in two different, in the International Journal of Prosthodontic Dentistry and in the International Journal of Perio and Restorative Dentistry. So different parts were published differently. But this is kind of stuck in my brain as a little mini nightmare and a stressor. So down here, I don't do inlays. I do direct. So I don't really worry about that stuff down there. But when we look at the crown preps, we go 70 for molars, 73% to 63%, depending on the amount of cutback you have. And 70 to 76% for bicuspids. It would be more for incisors, for lower incisors, it would be huge. And I think, all right, we're cutting away the outside of the tooth. This is assuming the tooth is completely intact. So they took these teeth and they, from the DEJ, from the DEJ, they measured the volume of the tooth and then they did the prep and they measured the volume again. And this is volume of tooth loss. Volume of tooth loss, 73% volume of tooth loss to do that. And then I think, well, all right, so here we have a big hole in the tooth. If we take away the outside, what's going to happen? So I look at this tooth not as, oh my gosh, it's a big hole, it needs full coverage. I see this when I look at this tooth. I see intact tooth structure there. And peripheral tooth structure is precious. It is the most important. When we look at studies that are loading teeth axially or obliquely, we see that the failure occurs at the margins. Mark Freeman, who's in the room here, did a study way back at UW where he had post and core teeth and incisors loaded to failure, fatigue loaded. Back then that was innovative, fatigue loaded with sensors. And before the post did anything, the margins failed. The tension margin would fail. You'd have failure peripherally first. We know feral concept is important. We know that if we have enough tooth structure, well, almost anything can work. And that's related to that feral concept, peripheral tooth structure. So peripheral tooth structure is everything. And I don't want to lose it. And so, the cool thing is have a way to manage that now. So when I see this tooth, I see this, or in my brain, I see what I would do to it to prep it. I'm not going to fool myself by filling it with a buildup to make me feel better, because I know that all I'm going to have left is a sliver of tooth on the buccal and lingual. And I know that I was taught that that's the right thing to do. And I did it for a long time. But I know now that our technology has taken us to a place where we don't have to do that. And that's what we're here for today. So of course, we're going to restore this tooth from within. We're not going to crown it. Wouldn't it be great if you showed up for the seminar and I said, so I decided to put some blue core paste in there and prep it? That would be hilarious. Maybe not. Okay, my little picture thing, I'm going to get that over there. So then I put Garrison sectionals on, and if the mesial was the same as the distal, if it was a true MOD, I would activate one side and restore that side. I'm going to restore the walls first. I would restore that side before the other side. So I put both matrices in. The matrices have to be perfect. This is one thing where it has to be perfect, especially as we get deeper. There has to be. So I work with rubber dam for all of these, and the matrix is placed, and I want to see it perfectly adapted to the cervical margin. And then I want to develop shape. Sometimes the proximal here isn't perfect, but I want contact. I want, when I'm looking inside, I want the matrix to be touching the tooth perfectly. No fluid, no blood, no nothing, perfectly isolated and perfectly adapted. Because when it comes down to it, finishing cervical margins is almost impossible. And cervical margins is the primary place of failure in these restorations. So I do the selective etch. In this case, I restored this wall just with a wedge, and then this wall. The process, though, is we do our 10-second etch, rinse and lightly dry. I use Protect Bond. Basically, I use what Dr. Satter tells me to use. He's kind of a disciple of Junji Tagami, and he's a bond expert. So when questions come up related to bond, I refer to Ellie. And I would suggest everyone do that too. He's brilliant, and his work with this is very innovative. So I use Protect Bond. If he says, Grant, I switch to this, I'm going to switch to that too. So he's one of my mentors. And I made a list once not too long ago, and it's a huge list. Anyway, Protect Bond primer for 30 seconds. The rules say 20, but depending on where I am in the dentin, I might go 30, so it's 20 to 30. Air dry, it's not like heavy air dry, but it's air dry. It should be shiny. Then I use Protect Bond adhesive. Lightly air thin it so there's no pooling, and cure. And the light depends on how long you cure. At that stage, before I switch slides, what I did in this case is I used Filtech Flow, a very, very thin bond line, just a thin line at the matrix tooth interface. The matrix is perfectly adapted. You don't get overhangs. It creates a seal at that matrix tooth interface. So I run a little thin bead very carefully up around that margin. That was until 2019. In 2019, Ali showed a study, a test he did of Bulk Easy by Danville, this is Ray Berlotti's thing, as a bulk fill material with his OCT. And what he found was the material shrinks and its properties aren't fabulous, but as a bulk fill material, and I don't do bulk fill, but the bond to tooth was perfect. The only thing other than fiber that he's seen where that bond interface is perfect. And that's apparently because of something in the polymer. It's a dual cure material, and there's something there that interacts beautifully with Protect Bond, and it dries and bonds right on the tooth first. We have to give it 90 seconds. So today, my assistant takes the Bulk Easy, which is in a double barrel syringe. We don't use the mixing tip, they're too big. We just put 2 drops on the pad. He mixes with a perio probe, and then I carefully place it at that interface, and then I wait 90 seconds. Once I do that, then I restore the proximal walls. And this is probably the most time-consuming part of this protocol is we don't want fiber to be outside. And we actually want it to be up the walls to create tensile strength. And so we have to rebuild the proximal. And that could be an MOD, an MODB, it could be a whole tooth, which, is hard. But essentially, we have to rebuild the shell in composite, and then we place the fiber within. So when we build the shell, it's a millimeter, millimeter and a half thick, depending on where we're doing that. Proximal is about a millimeter, millimeter and a half. If I'm doing the buccal or the lingual, it might be a little thicker. I use Voco Grandioso for that, which is a nano hybrid, and it's got very high fracture toughness. Other composites, APX, Majesty, Posterior, others would do well. I'm a Supreme guy. I was involved in early Supreme, like 2 years before market, and I love Supreme. I still use it, but it chips a little bit, and I noticed that, and I started using the Voco for marginal ridges. So I do that. When I'm doing this, I'm working out of a box. I use a Pelican 1050, I think it is, box that I've modified. So I have a paper pad in there, and I have my bonding agent and primer. And what that means is we can dispense our materials on the pad. I can use different composites, different shades, and I'm picking it up off the palette. And it doesn't take me longer to do that. It gives me control of the layers and the increments. When I see people using the Compule straight to tooth, they tend to overdo the layers, and that it hinders the ability to manage stress, and it hinders the ability to manage layers where we're putting fiber. So I work out of this box. It could be a retainer case. It could be other things, but that's what I use. So when we restore the peripheral tooth structure, we then now have a simple occlusal. So all this complicated stuff, whatever's gone in the tooth, once we've rebuilt the sides, all we have to do is laminate the fiber and incrementally build up our tooth, and there we go. So it gets easy. I mean, it kind of gets easy. You have to decide what fiber to use. So we're going to look at fiber. And there's 2 different products that I use. I use them individually and collectively together. They're different. Ribond, which is ultra high molecular weight polyethylene, known in industry as Spectra or Dyneema. One of the other in our group here today is Peter Shoemaker, who is just a great friend, went to dental school together, sailed together, and Peter knows all about Dyneema. Dyneema is used for high strength applications, low stretch lines, stretches like 0.002%. It's white, it's flexible, it doesn't interact chemically, so it's chemically resistant, it doesn't hydrolyze, doesn't break down in water. And it has an incredibly high tensile strength. So that, in addition to Ribond's lino weave, the way the fiber is woven, gives us both tensile strength and crack stopping abilities, as well as the ability to span a crack, which is if we can't get it out, we want the fiber to go over it. So that's the Ribond. Now, the Ribond needs 2.5 millimeters of depth to place, because you've got to have enough composite over the Ribond so the composite doesn't crack. Ribond isn't good in compression. This is similar to, like, way, way back, for those old enough to know, amalgam with dical or something underneath. If the amalgam was too thin, or if the axial pulpal line angle was too sharp, it would crack, right? The composite, I've had two composites crack shallow with fiber, and I realized it was just too shallow. So 2.5 millimeters minimum for that. Everex is glass, so it's chopped glass fiber. And I say chop because I'm a boater, and in boats, chop is the least effective way to strengthen a hull, to strengthen a structure, but it's easy. And so in this case, there's glass fibers in the composite, and it imparts actually really good strength. It's a lower shrinkage material, 1%. It resists cracking much better than normal composite. And so it's a tough material. It is not available in the US. So for the world audience here, that's something that they can sort of, smirk at us about. I found out from GC that they don't sell it here, not because they can't. It is FDA approved in the US, but it is, they didn't feel that there was a market here because our market is a bit insurance dominated and a bit one step and bulk fill dominated. And so they've chosen not to sell it here. I get mine from the UK or Singapore, a reputable dealer off of eBay. And so it's legal to have, but you have to get it elsewhere. I've heard some people say they use Shine in the UK to get it, but it's gettable. There's a new product from Everex or from GC called Everex Flow, and that has short fibers. And I'm not going to say anything about that right now because the fibers appear to be maybe too short to impart critical strengthening, and that remains to be seen. So I think people are evaluating that. I think Ali will probably look at that on OCT, and I'm not using it. So it's that's another product, and that is available in the US, but it's not the same as Everex posterior. One last point about Everex, it's a pain to work with, it's sticky. And so I place it, then I take a micro tip with bonding agent on it, but no wetness in the bonding agent. It's had bonding agent on it, and I get rid of the excess, and then I can use that to tap it into place, and that works marvelously well. So the handling of Everex is greatly enhanced by the micro tip. And I think I saw that, I had done that in the past with Vitramer, but I saw that specifically with Everex from one of Pascal's students at USC. It works really beautifully well. Okay, so if we're going to use fiber, we're using continuous fiber, which imparts greater properties and greater strength than using discontinuous fiber. So when possible, I want it to be continuous. It resists tensile forces also, which might be Poisson. If we have it up the proximals, extending on the walls and the floor, we're getting almost like a torsion box effect. We're getting resistance to wedging forces. And that's a big deal. Reduced shrinkage stress is happening and effective shrinkage. When I first did fiber, which was in like 1999, 1998, I did it because it was like fiberglass, except not. It was approved for dentistry. I thought of it for strength. What we've learned with Dr. Satter and OCT is that when we polymerize the rib-on layer, the rib-on to tooth part, the rib-on composite tooth interface is more or less perfect. The fiber to the bulk part of the filling sometimes gets little pulls in the fiber. So the fiber is essentially acting as a shrinkage stress diffuser within our polymerization. So we're getting stress reduction because of the fiber as well as the strength. So we see this better interface continuity on OCT. There's reduced micro leakage, partly because the bond line is perfect. It's not delaminating, which we see in other things. We can use fiber to stabilize cracks that we can't remove because we can't remove all of them. So that's being used here in Seattle on the West Seattle Bridge with carbon fiber and epoxy to span and secure cracks. So we can use fiber to help make our cracks that we can't remove more stable. However, when we do that, I tell patients the crack is still there and someday it may grow. So the best crack is gone, but I'm not going to prep a crack out into the pulp chamber. So unless it's a D-vital tooth, of course. But so I use fiber to span cracks. And then fiber has the lino weave in rib-on actually has crack stopping characteristics. So if a crack were to start, it kind of stops at rib-on at the nodal intersections of the fiber. The two cases where I put the fiber in a tooth that wasn't deep enough, the composite above cracked and it stopped at the fiber. It didn't go into the tooth. So those are just anecdotal, but still they build confidence. And then we have protection against catastrophic failure. So when teeth are loaded to failure in studies, whether they're fatigued or not, eventually there's a point where it's load to failure. So when you have teeth that are caused to fail in a study, one of the questions is, how did they fail, and is it restorable or is it catastrophic? And interestingly, fiber reinforced teeth fail peripherally. They don't fail down the middle. They don't split. So the fiber protects against catastrophic failure. So this is going way back. I had been doing fiber prior to this, but I wasn't prepping cracks. I wasn't restoring the proximal first. I hadn't even gotten to sectional matrices at this point. And this was an old amalgam that I took out, and I didn't take a picture till I saw the crack. And you can kind of see the crack here. There's three. There's a distal marginal ridge crack, and this crack on the pulpal floor, and then this cusp is cracked. Didn't deal with that. And at this stage, at this point in time, I was using Scotch Bond multi-purpose plus adhesive and Z250, and not prepping out the cracks. So the fiber looked like that. I didn't extend the fiber to the margin, so there's still composite going in, but that was going in one step. You know, if I was in a really fast-paced practice that had to do things quickly, but wanted to get the benefits of fiber, I might do something like this: place the fiber, then do my filling. It's not going to get the tensile strength advantage, but it will get some of the advantages. So that would be a way to do a, good, better, best, maybe better, but not best, an idea. So, and this was the tooth when I finished. Again, I didn't address this crack, and it did extend in, but not across the floor. So today I would have gotten rid of that. And today I would have built the proximal first. So then this is 2016. This patient, so I recommended a crown because it was 2001, crack in the floor of the tooth. I'm going to recommend a crown. That's what we do. We want it to not grow. But the patient didn't do it. And it didn't become symptomatic. In fact, we did fiber in 2 more teeth. This was gold. You can see it a little there. And this is what fiber looks like on X-ray. So you can see the fiber itself is radiolucent, and you get this funky look on X-ray. So if a dentist sees this, they're liable to think there's something wrong. And we've seen a couple of cases of that apparently at the UW, where the prosthodontists say, "Oh, that's a big filling, we got to crown it," and then they prep into the fiber. So there we go. Now, this is kind of interesting. This is 16 years later, and this tooth is still going fine. I just don't have excuse me, I don't have a newer picture of it. But so we look at this, and there's, kind of some wear from some bruxing habits going on. There's a teeny bit of margin leakage here. These cracks were present before. And so all of this looks pretty similar. This tooth got an occlusal composite 2 years later with a resin with a Vitramer, the 3M product, a Vitramer resin modified glass ionomer base. Back around 2000, when I was first doing these, I had a lot of conflict between resin modified glass ionomer or fiber, because and our bonding to dentin was not so predictable. The glass ionomer was pretty highly regarded, and so I went back and forth, and I had some kind of conflict about that, which I don't have anymore. But this tooth in 2003, then 5 years later, the opposing tooth was extracted for, I can't remember if it was, I think it was a crack-related perio pocket. And look at the cracks on this tooth. So this is the margin all the way around is leaking a little bit, not terrible, but just a bit. And there's some cracks that have come around. So if we look before and we look after, it's different. So we see these same crack lines here. They're a little more stained now. There's a lot more wear on the occlusal from just life. But this tooth didn't really have any radiating cracks. And it did, and it didn't have any occlusal forces after 2008. So So you wonder about how the fiber affects shrinkage stress. This was also one of the early, I'm not going to get into this today, but we will talk about these kinds of things next time a bit, time permitting. In 2003, this was my hygienist at the time, Carrie. She was from Virginia. Her dad is a dentist, her brother's a dentist, and her tooth had been reamed out a bit. Partly it was a root canal when she was very young, and then reamed out to bleach, and they did some composite bonding on it. And so we cleaned this out. We cleaned out the tooth, and it's a shell, and it's intact, but there's nothing there. So if you do a crown on that tooth, there's nothing left. You're relying on a post. And so I didn't do that. I actually laminated this internally, peripherally, and then we replaced this with a no prep veneer. The tooth was already a little prepped and stuff, and so we cleaned it up and did a very thin feldspathic veneer. And this is 2016. She moved back. She moved to Virginia. She moved back, and I got a picture. So this is the tooth. I'm not sure what happened here, but still going strong all that time later. So some of these things I'm showing you, I started doing them without evidence other than it seemed right. And then the evidence came later. And I didn't talk to dentists about this until we had evidence. It would have been unethical. So we've got, there we go. All right. So Carla, there's a couple people that were in the waiting thing. All right.
Got him.
So 3 more studies or so, and then we'll move on to the case, back into it with the fiber. So here we have somebody who had class 4. They put a little bevel with their composite, and then they did fiber. And the intact tooth, failure rate plus or minus 100 newtons, was 435. The rib-on group, 434. It's identical, almost identical, certainly statistically identical. So the fiber on the tension side, so the lingual side of a class 4 is in tension. So it's, you know, the lowers we're doing this. And so it's wanting to break out that way. If it's going to break from chewing and occlusal forces, almost the same as an intact tooth. Pretty cool. This was a 2011 study. And then very early on, Sema Belli from Turkey, who also got her PhD in Tokyo Medical Dental University, as did Dr. Satter, did this early study. So the prep wasn't perfect, sharp line angles. She did an inside and an outside overlay type fiber. And the inside was 23% higher fracture resistant than the composite. The overlayer absolutely was stronger. And the question with that is how much tooth do you have to take away, and how thick is the composite over the fiber? Would that break down? I think it's risky without more space. So so this also shows off the benefit of the tensile strength of the fiber. And then she did another study with rounded line angles and broke off the lingual cusp, reattached them, and then and did these various restorations. So she had the unrestored tooth, MOD unrestored after she reattached. So it wasn't very much, it was actually a little stronger after reattachment, which is weird. And then MOD with APX, bond flowable in APX, and then flowable fiber in APX. And you can see that we're very close to unrestored tooth with the fiber. This gives great confidence in what I've seen subjectively, restorations lasting a really long time, and then seeing validating data. It kind of reverses the picture. You see validating data and you say, well, yeah, let's see what happens. But we've seen that, so that's kind of cool. All right, back to our tooth. So So normally I'm thinking about this as I work, but we'll talk about it here. And this tooth has a very steep, very deep box on the distal, which you can't see. So I decide that I'm going to use sorry. I decided I'm going to use 3 pieces of fiber, but first I'm going to show you how we prepare the fiber, then we'll do that. So we take the fiber, we pick it, we cut it, we measure at the perio probe, we wet it in unfilled resin. I use I use Protect Bond Adhesive. It has to be thoroughly wetted, but not swimming in it. So you thoroughly wet it, move it off to the side, dab it with your gloved finger is enough. And then I put Voco Grandioso out in sort of a ribbon form, place the fiber on top, press it in, trim off the excess, peel it off the pad, and then we're ready to move on. If we're going to use the rib-on securing resin, we do the same first 2 steps, get it wet with the resin. I like the Protect Bond and the SE Bond adhesive because Ali does. It has MDP primer, which is an advantage. So I like using that. And then this works quite well, actually. So we did a study this last year looking at adaptation of my way, which is the top way, the rib-on securing way, and using flowable. And the rib-on securing way and the Voco way both work really well. The Voco way adapts a little better to convoluted surfaces, but the rib-on does okay. The flowable doesn't do very well if the surface is multiplanar, if it's up and down or up the walls. Very difficult to get it to stay adapted. And taking the time to adapt this, make sure you have to sort of go back and forth to make sure the fiber is as close to the tooth as you can get it and well adapted. The other risk with using the tacky composite or the securing composite is putting too much in the tooth. So we don't want to just plop the fiber in a pool of resin. That's going to defeat the purpose of the fiber. It needs to be well adapted to the tooth. All right, so here I took a piece of 2 millimeter THM Ultra. And once again, there's 1 millimeter, which is called ortho, we wouldn't use in this. 2 millimeter, 3 millimeter, 4 millimeter, and 6 millimeter. And there's special cutting scissors for that, or you can use an ultrasonic knife, which is a little more expensive, a lot more expensive actually. So here I put 2 millimeter THM Ultra, and then I actually placed a little bit of Everex posterior over that because my design was I'm going to put the 2 millimeter, then I'm going to do a wrap, then I'm going to put another piece. And the wrap is really hard to do, as you'll see in the next slide. And I wanted to be not on a 2-shelf kind of a setting for that. So I did the 2 millimeter fiber up the wall, up the buccal and lingual, and then I added a little Everex to get up to the same plane, and then move on to the next one. So we place it, carefully laminate it, carefully adapt it, and cure. And then this one, oh, this is hard. So you have the, kind of measure. Sometimes I'll do floss, figure out how long that's going to be, get the fiber prepared, and then, and this I don't think works with tacky resin. It works with heavily filled material. And then I have to make a little loop smaller than the hole of the tooth and sort of set it inside and then expand it all around and get it adapted and then cure. So it creates internal circumferential ring, which is incredibly strong, but very, very hard to do. And on a bicuspid, much harder than on a molar. And there has to be, again, enough depth. The fiber should not go to the cavo surface margin. Within 1 millimeter is fine, but somewhere around halfway up or within 1 millimeter, but not closer than that. We want to have our occlusal margin well into enamel for the enamel dent bond. Okay. And then finally, I took a piece of 4 millimeter, pretty small piece, and put it in the middle up the sides a little bit. You can kind of see it overlapping here. So it's just in here, and that's creating that reinforcement along the floor. After this, I messed up. I took a bad picture apparently, and then I skipped a picture. Back then I was taking my own photos. Now I have an assistant who's helping with these when I do it. And so we're going to skip next to kind of the restoration before checking occlusion. But after this, I put a little more Everex, and then I use Filtek Supreme Ultra, and I'll use different shades just depending on how I feel and what the tooth looks like. In this case, I used A2B and A1E. All right, so here we are before and after, and then we're going to take a look after the rubber dam's been removed and I've adjusted occlusion. I do usually pretty simple anatomy. It's not, super elegant necessarily, but depends on the other teeth, adjacent teeth, how much wear a patient has. I think if it's really super beautifully anatomic, it also creates a greater chance of cracking. And so in this case, it's a very simple anatomy. What I love here is there's no horizontal cracks. If I had done this with composite, the buccal and lingual walls most likely would have cracked. And then here's an X-ray in 2021. And you can see the wall thickness. You can see the disparity between the box and the rest of the occlusal floor. And this so far has been just doing perfectly well. No signs of problems, no signs of cracks, no symptoms, no pulpal involvement. It's just fine. Okay, great service for the patient. I saw that, William, I can answer your question. We're almost done and I'll answer your question when we finish, if that's okay. So we're gonna finish up here with some of the benefits of biomimetic dentistry, which is offering us the opportunity to change the future, which is huge. It's basically trying to preserve teeth over a lifetime and doing that in that tooth preserving way. Biomimetic techniques strive to preserve healthy tooth structure, first and foremost, which starts with, as Graham Milicich so beautifully talked about in his first webinar, true prevention, preventing caries and turning off the caries process. Graham also talked about how using that to grow his practice is somebody said, well, what that takes away your work, but he tries to use it as a practice builder when he was practicing. We're maximizing bond strength. We're minimizing induced stress and strain in the teeth being treated by skillful preparation design, careful selection and use of materials. And these are things that are taught at various courses and places that teach biomimetics. And Matt Najad has a seminar series. Simone Delaperi and David Alleman have a series. At this time, Ali's done a AGD thing. We're talking about doing something, but as of yet, we're not doing a formal hands-on type of a setting, but that's a way to improve as well as reading the literature. We create value for our patients, not by the price of what we do, but by the durability and reduced treatment escalation. So now the elephant in the room. Anybody who practices in a fast-paced setting is going to be saying, we're not going to do that. So this technique takes time. Everything we do in biomimetics takes meticulous attention to detail. So it's not particular to this. Bonding requires isolation, managing the layers, managing the hybrid layer, managing the bond interface. That's true for all of this type of adhesion. I think sometimes it's better not to do adhesive crowns. If you're not going to do the steps, it should just lute it in, because poorly done adhesion is going to leak and fail. So it's tricky, right? And it could take 2 to 4 times as long. I did a really, really crazy one this week that took me 3.5 hours. The fee was really high, but it was way, way lower than it would have been if it was crown root canal, crown lengthening, and buildup. So the patient actually felt great about it, but couldn't possibly be done for insurance fees. So fees must be reasonable to compensate us for our time. And this isn't about more, but it's about, I tell patients, the fee is about giving me the time to do this properly for you so that it will last. In the US, insurance fees aren't going to do that unless you're able to bill separately for the fiber. So I don't know how that works for in-network people, but it's something that needs to be, we've been talking about this, I think, in the ABD for 5 years. Need to look into it more. There was an effort to maybe get fee codes for biomimetics or for fiber, but I'm afraid that if that happens, if insurance is going to cover it, it's going to be bad. We know how that goes. It won't work. It won't be viable for the time spent. So I don't have an answer to that elephant in the room, but it's still there. It's still a question. When we help our patients understand the benefits of what we're doing, and I do that as I'm working with I have a Digidoc Iris HD camera. I switched from a claim that was not HD. The pictures are good enough to show in presentation, although not without an apology. They're not great. They're pretty good though. They're great on the computer monitor. And I take pictures of all of these as I'm going and I talk to patients. I try to help the patients understand that what we're doing is not a simple filling. And when we do that, we use the word filling for fillings and restoration for what we're doing. We talk about how what we're doing is to help make the tooth whole again. And nobody complains. People are so happy that we didn't have to grind their tooth down. We encourage them to refer friends who might be grappling with the crown issue. And so we try to build our practice for people who want this kind of dentistry. And that creates a niche for people who are interested in this. It's also potentially beneficial for environments or for populations that just can't afford crowns. So you can do it and have a way to maybe make it work longer than a few years. All right, so that's the formal end of the presentation. I hope you'll join me on March 27th to continue exploring the possibilities of direct fiber reinforcement. We are going to be looking at these teeth, and it'll be interesting. So I haven't put the exact mix of cases together, but it's going to be less science, more teeth, more cases. I would encourage anyone who's referring a colleague to maybe get them to see this presentation so that they understand the basis for this before watching the second presentation, because I'm going to do much, much less on the science side, much, much more on the clinical side. Kind of a flip of what was originally asked of me. I couldn't talk to you all about this without going through the fundamentals. So I appreciate your kind attention, which is weird because I can't see you out there, but thank you. And we will close for a second with Carla, and then I'll stay here for questions.
Thank you so very much. What an awesome presentation. That was just wonderful. I'm sure everyone will agree. Thank you, thank you, thank you. We will be doing our question and answer here in just a moment, but I'm going to go ahead and share my screen. And for those of you that did purchase CE for today's presentation, this is the code. Go ahead and take a screenshot. Use that. I will drop this code also in the chat for everyone. And 1 second here. All right. Drop this in here. Sorry, just trying to get over to the screen. All right, there is the code for everyone. We also will have our next presentation, as Grant mentioned, coming up here on March 27th. So make sure to register. Registration is live right now. We are also offering a $10 off code that is good for just today if you do register. That code is ABD10. So if you use that in the checkout when you register, ABD10 is the code to save $10 off of the next lecture. So that's pretty cool. I am going to start with a polling question. I meant to start it right at the beginning, but we're going to just get this one polling question out of the way. If you see that, go ahead and take the poll. It's a pretty easy question. All right. Couple more coming in. Great. Just to let you know, we are the Academy of Biomimetic Dentistry. If you are not a member and would like to become a member, registering is just as easy as going right onto our website. Website's listed right here on the screen. Members do get access to the recording of all of the webinars that they have attended. So when you log in, you can access this recording and the others that you've attended. You'll also have a Find a Biomimetic Dentist. It's a search feature on our website. So those patients that are looking for a biomimetic dentist can find one. A couple other of the benefits, you get to be a part of this awesome community of biomimetic dentists and access to your member level content. There's videos and case studies. The Academy also has a fellowship and accreditation program so that you can go through some of those trainings, present some cases, be partnered up with a mentor, and really learn the structure of becoming a biomimetic dentist. There's a test on our site. So all of that can be found at www.aobmd.org. And there are some advanced features too for advanced memberships. We also have some videos and marketing materials, really cool stuff there. So if you are not a member and you'd like to become a member, please go online, register today. If you have any questions, you can reach us on our contact form. You can message me in the bar. Matt is also not here with us today, but he is can help you with any of those questions as well. So that is how you become a member. Don't forget, 2 weeks from today, Saturday, March 27th, Dr. Grant Chyz is going to be presenting again. So just more of this awesome presentation, and we'll learn so much more. So feel free to register. Again, that link is in the chat, and you can register and save $10 today with that code ABD10. Met somebody here. I'm going to do a second polling question. It's not going to come up on the screen, so feel free to answer in the chat. This is a question. In biomimetics, when placing fiber, you should A, adapt the fiber as closely as possible to the prep, B, cut it up into little bits and sprinkle it into your first layer of flowable, C, size your fiber to allow extension slightly up the walls of the prep and across the floor, D, wrap it around the tooth to make it a ferrule. E, both A and C. Feel free to answer in the chat. And Grant, you can probably see these coming right in, huh?
I can see poll 1.
Oh, I'll close that. Lots of E. E.
Smart group.
Smart group. Wonderful. Again, for your CE requirements, you must have purchased CE to receive it and have attended today. You will need to use code GC031321. Please make sure you take a screenshot. I've pasted it in the chat, so go ahead and use that. You will need that code for your CE. If you did not purchase CE and have attended today, please private message me in the chat bar, and I will make sure to get you taken care of. CE will have to take place for today. We will submit that out. So thank you so much. I'm going to turn it over to Mark, and we're going to start our question and answer segment. Thank you, everyone.
All right. Well, thank you so much, Dr. Chyz. That was amazing. I mean, it's something we have to replay over and over again. So hopefully those of you will rewatch this again and take as much as you can from this. Also like to thank Melissa Siebert and Dental Digest for their sponsorship for the CE and their fantastic dental podcast. So please check that out. So we have some fantastic questions, and feel free to continue asking the questions in the chat bar so we can continue the conversation. Let's start it off by asking this question. For teeth with enamel peripheral cracks that only have enamel peripheral cracks, why not leave them in and place rib bond on the mesial and distal wall with the composite rather than tracing them down?
Well, you could do that if they're only on the proximal walls. I don't think we've explored the odds of them propagating into the dentin. The question is, that's a reasonable question, actually, and I don't actually have an answer to that. It's possible that would be enough. We do see bacteria getting through cracks, the so-called invisible caries or what I call crack caries, where there's, caries going through cracks into dentin. So we definitely have a sense that there can be leakage through those cracks into that dentin. If that gets into the bond interface, that can affect things. But if we're well sealed, I don't know. I think that that's a reasonable question. I'd love to explore that over time with research. It's hard to figure out how to do that. So it's a very good question. I'm sorry to say I don't actually have a good answer for it.
Well, following up, if you did you proactively remove old occlusal amalgams? There may be cracks that are not visible there, but you also may be creating new cracks by having that amalgam present. Do you proactively remove old amalgams?
I do when there are, when risk factors are showing up. So I did a 320 tooth study in my office. I didn't publish it, but it was a study of consecutive teeth that I was working on, whether they had marginal ridge cracks or not, and if they had stained or significant, what I call not a craze line, marginal ridge cracks, kind of like the mesiolingual crack on the tooth that we worked on that I showed in the study. Nearly 50% of those extend onto the dentin. So it was like 44%. National Practice-Based Dental Research Group, I think, did another study looking at some of that. And there was a number that was like 65 or 70%. So if I see like the bicuspids I showed at the top, the three, depending on the patient, I might show them on a camera, and I might say this tooth has an old amalgam. It has these cracks over the sides. Those cracks may extend into the tooth, and if they do, that can affect the lifespan of your tooth. It could even lead to splitting it and losing it. So if we choose to, we could take out the old filling, evaluate that, and manage the cracks before it goes deeper. And I think the very best treatment we can offer is appropriately proactive, but I can't tell the patient they need it. I think I have to explain that I see something that presents warning signs, and that, the worst thing that happens, frankly, is we take out the composite, or we take out the amalgam, if it's an amalgam, and we manage the stresses inside, we change the line angles, and we do something that won't crack more in the future. That's not such a bad thing, especially if it's a 20, 30, 40-year-old amalgam. So yes, I do recommend that, but I don't do it the same way I would if somebody had an abscess or decay or a painful tooth. It's more elective, and I present it that way. I present the advantages and the disadvantages, and I would say, I don't know, 2/3 of my patients do it. Some of them think about it and do it later. Some of them are just like, as long as it's okay, doc, I don't mind. I give them a Pete Dawson quote often, which is to help them understand this, which is also Pete Dawson. And that is, in dentistry, signs often precede symptoms. And so looking for the warning signs of disease can help us prevent greater problems later. So I think how we present that matters. When I did that article, the at-risk tooth, I got one 2-page handwritten hate letter about how in the world could I think of drilling into teeth with cracks like that. So obviously the idea doesn't work for everyone. That's why I showed the studies ahead of time, is to show the propensity with which cracks do propagate and the role they play in failure for all of us. So being appropriately proactive, I'm certain, is the best treatment for patients. How we talk to them about doing that is another question.
Thank you. Follow-up question to that one. We know that the goal is of Biomimetic dentistry is to keep the nerve vital at all costs. If you have a tooth that is not symptomatic, but you see some signs of cracks propagating with an old amalgam, and you wind up electing to remove the old amalgam, and you reconstruct the inner aspects with the ribbon, with all the techniques that we have, and we structurally make it as sound as you possibly can, but now the tooth becomes symptomatic, and you wind up needing root canal therapy. If they get the small access hole through the tooth and do the root canal, and you reconstruct the access hole and build it back up, is that tooth more structurally sound having had the root canal than having left it alone without, disturbing it?
I was going to say, could you read that again? But,
That was my question.
that's your question?
That was my question, so I can't.
So the tooth with the root canal is almost 100% of the time not more structurally sound because it's got a root canal. But if it's, so the question is, why does it have a root canal? Is it because of the crack or is it because of the decay? So diagnosis doesn't stop with root canal. That's like cavity. Patient has cavity. So yeah, we need to drill out the cavity and do a filling. But why do they have a cavity? Because if we don't determine what caused the etiology of the decay, we're not helping them prevent decay in the future. So we're not fully diagnosing. So if we have a tooth that needs a root canal, my first question is why? Was there a pulp exposure? Was there dentin infected through deep decay? Or was there a crack in the first place? And how did we manage that crack that was there in the first place? So if it's a deep crack, we might decide, I haven't run into this. Basically, I haven't run into a fiber reinforced tooth that was asymptomatic, becoming symptomatic and needing treatment other than a split. So I honestly,
I guess more in the absence of decay, if just the trauma of drilling out the old restoration and doing the work puts the person over the edge to become symptomatic.
So if that happens, that's probably creating or growing a crack, maybe a defect that pre-existed in the tooth, but that becomes crack based. And so depending upon where the crack is that triggered the root canal, because if it's like worked on the tooth, it was fine, did the work, did the buildup, and then it got symptomatic and it needs a root canal, that's almost certainly crack and or leakage and crack. And so if the endo happens, then the question is the chamber or the canal cracked? And that means the endodontist has to have a microscope. They have to know how to look for that. So when the one endodontist I work with is right here, although he's not sharing his screen or his view, it's Mark Freeman, who really started, he's always like, why does this tooth need a root canal, right? And so Mark, there he is. Mark would look at a tooth that needs endo, and the question was always, what is the etiology? Because you can only hope to have success if you understand how and what you're trying to deal with. So Mark has been a brilliant partner in my journey through dentistry. My life wouldn't be the same without him because of his thoughtfulness related to that. So I'm not trying to not answer, but I would say that if for some reason you had to do endo through Ribond and it was conservatively done, and you sealed the endo and then you put Everex in there and composite over the Everex, I think you'd be pretty close to the same. If it's a big chamber, I would want to deconstruct the fiber and do it over.
All right, makes sense. Here's another question someone asked. This person said Tagami had taught us not to selectively etch the enamel. And then what are the pros and cons of doing so? And how does selective etching of the enamel affect the integrity of the DEJ?
I'm going to refer that to Ali, who's sitting here too.
We have Ali Reza Sadr here with us.
We do. He's my bonding sensei.
Yeah, if you're using a two-step self-etch like Protect SE and SE Bond, you probably don't need to do a selective enamel etch. If you have good isolation, if the tooth is clean, especially if it's air abraded with aqua care or something like that, I don't think you need to selectively etch. But in reality, there are cases that I do myself selective etch once I feel like the margins might involve some sort of uncut enamel, the cable surface margins and all that. There is debate still in TMDU on that. 5 seconds of quick etching on the external enamel surfaces, I don't think will be bad, but you don't want to, of course, total etch or put that etch for 15 seconds or 20 seconds.
Okay.
That's my answer.
There you go. It's a good answer. I like that. All right. Another question is, when using multiple pieces of ribbon, are you placing and curing the individual pieces? Are you placing them and curing them together? Are you overlapping them? Referring back to like when you did slides 50 and 51, especially.
Right. So those, I'm looking over my screen. Right. So no, those are, so I don't wallpaper. I don't do bunches of little pieces overlapped, although it's certainly better probably than not. When I'm doing those, I place it and I cure it. And so I'm doing it because the geometry of the tooth, the size of the hole made me want to do the wrap. If I can get the 360-degree horizontal wrap, it just really makes sense. It's structurally really good, but I don't do that by itself. So I'll put some on the floor, and the idea that I put a piece on the deeper proximal first was unusual. So I cure them individually. We don't really want to increase the depth of materials that we're curing. We want to cure thin layer on the tooth interface, and we don't want to build up a bunch and then cure it. It creates different stresses, and much of what we've seen in research might not hold true if we were doing like 3 or 4 layers of fiber. I don't sort of pancake fiber to make it thick. It's getting the liner, and then I use Everex for the bulk part in incrementally placed though.
If you were doing the circular onion layer of the rib bond, and you have, let's say, 2 J-shaped pieces that overlap, would you cure one J-shaped piece and then cure the other one, or would you place them both and cure it together?
No. So the fiber doesn't have a memory like sort of Everstick or the glass fibers. It's pretty passive, but it doesn't automatically stay bonded, stay adapted to the tooth structure. So I will fuss around getting it really well adapted, and then I want to cure it. So I'm not going to let it sit while I try. First of all, I don't do J pieces. I do it all the way around. But if you're doing J pieces, which is like half and half overlapped, I'm going to do one and cure it, and then do the other and cure it, because I don't want the one that I did before to get messed up. So absolutely one and then cure. And if they're J pieces like this, I might cure a little less time than I would, and then do a longer cure at the end after both of them are in. But I'm going to cure it.
Okay. Next question. I'm guessing this is based on one of those slides where you showed a few pictures of the amalgam. They said slide 26, if I remember correctly, might have been with the pictures of the teeth with different amalgams in there. And then the question is, what do you propose to the patient in the initial treatment plan, since not much yet is known about how you will restore it? So a lot of times you take something out and you're saying, we'll let the tooth structure dictate what needs to be done. But when you're treatment planning, how do you propose the treatment plan and quote fees?
Well, that's a good question. And with these restorations, almost always we're ending up with a direct. And the patient understands that the condition inside, I explain to them, I show them a picture, I explain to them that the condition inside the tooth is going to dictate where we go with this. We're going to set up the appointment to remove the old restoration, the old filling, I say filling, and we're going to clean up any decay and evaluate structure. At that stage, we're going to hopefully restore the tooth, remove any cracks if they're there, and restore the tooth as is. But if we need to do a crown, if it needs more, then the filling that we're doing will become a buildup, and they'll need another appointment for that restoration. And that's really rare in my office. So you can't look at that tooth and say crown. And frankly, if I tried to do what I did, which on that tooth I think took me, I took pictures. Pictures make it take longer. So I think that took an hour and a half on that tooth. And if I was doing it just to do it with the intraoral camera, it'd be an hour, about an hour. But if I do that and I try to restore it and I go through these steps and I'm careful, I don't have time to just do a crown prep at the end. I can't schedule that much time. I can't afford to waste the time of a crown prep. So they're going to have to come back for that. And they're on the rare situation where for some reason I decide I need an onlay or I need something else. They understand. They're okay. I'm very talkative with patients. I'm showing them pictures. I'm explaining what we're doing. I'm explaining how hard we're trying to save their tooth and the steps involved. This is not in a vacuum. There's a ton of building value in the process with patients. And I have a low volume practice with high patient retention. So a lot of my patients just trust me completely anyway. I've earned that with them. So it makes it a little easier over time. A new patient, I show them more, I talk more, I help them understand what we're doing and why, and I check in to make sure this is the direction they want to go. I don't see the complete wide swatch of everyone and everyone's community and everyone's different conditions. So the patients that are getting to me are referred. They're mostly working. They're wanting to understand a bit, and it's almost like each of our practices self-selects a little bit. We attract for the atmosphere we create, the type of practice we have, the environment, the community we live in, and that seems to be what we do to grow our practices. And in my practice, patients get a ton of information and a very clear effort not to sell the dentistry, but to build value in the reasons behind what I'm recommending.
I mean, a lot of it goes into, as you're saying, patient education. And in your practice, in my practice, and a number of other practices, we may have the time or the ability, depending on the kind of practice we have, to take the time to educate our patients properly. Sometimes we have patients that are in more of a insurance-based practice, and we don't take the time to educate them necessarily, or procedures based on the insurance. But when you are trying to do proper biomimetic dentistry techniques, you need the time to educate our patients. I know the Academy of Biomimetic Dentistry has an advanced membership where we have marketing materials for you, and we help you promote your biomimetic dentistry. So I guess the question to follow up with you is, and I know you touched on it a little before, but for those of them, everyone who missed it or wants to hear more, how would you build value into the type of biomimetic procedures you are performing when speaking to your patients?
I thought I just sort of talked about that.
You did. I just wanted to
Yeah.
reinforce that for everyone.
Yeah, no, it's really important. The building of value is super important. It's on my website. Issues about, I heard Pascal use this term. He coined, as far as I know, biomimetic term, but I like actually tooth conserving dentistry, because really that's the focus, and that spans the whole range from trying to prevent the first decay, being very minimally invasive and conservative at the beginning, to how we actually restore teeth if we have to try to make them not grow from middle size to large to whatever. That's that cycle of death that Dr. Tagami, Dr. Sorensen, Dr. Satter have done various, and Pascal, various illustrations of. So to be full and complete, website, and then we talk to patients a lot. So I'm not a heavy promoter. It's just my personality that way, but I'm very comfortable talking to people, and they can't know what we're doing unless we explain it to them. It's impossible to intuitively know the value of what we're doing if you're just sitting there doing the most amazing job in the world, this kind of work that takes longer and the fee's higher and the patient goes up front. They're going to be enraged. They're going to just have a fit because they don't understand what you did for them. So we have to help them understand that in a positive way. And it's really positive treatment. I love doing this. I love rebuilding teeth. And I think that comes across, and patients, when explained, when they're given the information, they love it. By the way, 2000, I think it was 2000, 2002, I did some stuff with 3M. They commissioned a study that looked at patients' choices when given options. and it had to do with money. And the answer they found in this study was that when patients are given information and opportunities, they don't specifically make the choice for money. They will find a way when there's good reason. So the idea of prejudging whether somebody will or won't do a procedure, I found is just a huge mistake. People surprise me every day. Some who I think could afford anything on the planet who just don't value it, and others who are a waitress at a restaurant who are compromising their lives to be able to afford to come to my office so I don't do a crown on them. It's people are amazing, and I think we just learn to work with them. I don't know.
Now, you did something very clever that I haven't seen much before, where you number your slides so we can go back to refer to it. So now that we have those slide numbers, we do have a number of questions regarding certain slides.
Yes.
So if you don't mind going back to slide number 32, there are 3 questions on slide number 32.
That means resharing and doing that. Can I just talk about that?
Yes, I'm not sure which slide was on there though.
So that was the cracked marginal ridges prepped out.
Yes, so one question was, would you consider bridging the mesial crack with rib bond as opposed to removing the mesial wall?
Yes.
And
yes, I would.
Okay.
And I thought I mentioned that there are times where I don't cut out that crack, and there are times where I do. It sort of has to do with how it looks, but I'm not sure how the rib-on over an existing crack that goes all the way through the wall is going to support that over time. I'm just not confident about that, so I'm not going to present that as an answer, but it is a possibility that I think about myself quite a lot. Whether to leave it or take it out, there are times I leave it and there are times I take it out, and I've been thinking about why that is. And the partial answer is I don't know for sure that the fiber is going to do enough there. Whereas I know if I get rid of it and bond the interface, it's going to be bonded and not leaking. So that's the best I can do on that one.
And how about the remaining, and the follow-up question was on same slide, how about the remaining mini cracks in the enamel of the box?
Never going to take those out. Then you might as well just do a crown because they're all cracked. If you put a flashlight or a intraoral light, transillumination light on that tooth, there's going to be all kinds of craze lines. I never, ever recommend crowns for craze lines, ever, never.
Another question with the same slide is, why not put an onlay on this tooth also to protect the cusps?
You could. Yeah, you certainly could, for sure. It's taking away more tooth, and the risk of the filling, the restoration that I did is that you could get marginal chipping a little bit, but that's easily repairable. If I go to taking the cusp off, I've got to take enough to have enough composite so that it doesn't just chip. And I don't usually do that, but there's nothing wrong with it. It's certainly a viable option. I think, yeah, certainly viable.
There are a number of questions asked in different ways regarding the use of Everex. One question is why not just restore the whole cavity with Everex posterior and then in combination with some regular composite afterwards? And the other follow-up question is, what is the difference between putting rib bond on the wall and Everex in the posterior?
Right. So Everex, you could do that with Everex. An upgrade from a bulk filling would be using Everex internally and then composite over the top. That would be an upgrade from a standard composite. Everex does not have tensile strength. It doesn't have the cracks. It has crack stopping abilities because of the scattered chop within the fibers, but it doesn't have the crack stopping ability that the rib-on has as far as tensile strength. So it has benefits, less shrinkage, more fracture resistant within itself, but whether that's going to impart that on the tooth is not at all clear. Studies using Everex mostly do quite well. And I think depending on how you're managing your time and all of that, it's a reasonable alternative. It's not doing the same thing though. So it's not creating tensile strength. It's not creating the crack stopping capabilities. And the bond interface may not be as perfect with, if you were doing Everex, you might want to do a flowable or a bulk easy coating over the dentin slightly before the Everex. Up on the walls, it's not providing the kind of support that Everex provides when it's part way up the walls. So there's I think a lot of confusion about that, and that's why my goal is to use the terms for Ribond as continuous fiber rather than the interrupted or the discontinuous fiber of Everex. So if you go from Everex to small pieces of fiber, that advantage that I'm seeing with the continuous fiber may be diminished. But nobody has tried to yet do a study that compares those. So the answer has to be still out there.
Okay. Once you laminate the polyethylene fibers along the inner aspects of the tooth with the Ribond, do you also like to fill up the base of the dentin portion with Everex on top of the Ribond, or is that just too much overkill?
I do, if there's room. So in the past, I used to use Voco. After I put all my fiber in, I would fill the subsurface part of the remaining cavity, the remaining hole, with incrementally placed Voco Grandioso. And then the top layers, the occlusal layer, the top layer is Supreme. Low wear, very aesthetic, polishes nicely, holds up well. Today, I do what I was doing with Voco with Everex. So if there's quite a lot of space left, that becomes incrementally placed Everex to the subsurface layer, followed by my surface composite, which is in my case Supreme.
Okay. And the person asked a question: if a tooth has no cracks, would you still use Ribond? In other words, do you use Ribond in all restorations instead of just regular composites?
I love that question. I love it because absolutely I do. So there was a point, maybe 5 or 6 years ago or further, I didn't. But there's a point, I look at this stuff with Dwayne Arola. I look at all this stuff. Ali and I talk about all this stuff all the time. I look at all of that and I'm like, these teeth break down over time. Arola's stuff tells you that everything we've touched is damaged. Everything is damaged. So why do we wait for visible cracks? His research says there's cracks in there. There's defects and small cracks. And so if there is room, meaning that 2.5 millimeters, if there's room, I put fiber.
All right.
Absolutely, yes. Because I don't want it to crack in the future. So I do.
Okay. I agree. I like that answer. When a lot of the dental tissues are missing, why proceed with a direct restoration, not a ceramic, given that ceramic has an elastic rate closer to enamel opposed to composite, which the elastic rate is similar to dentin and leads to cusp breakage? That's the question.
I haven't seen cusp breakage at any significant rate with fiber reinforced, with continuous fiber reinforced restorations. I saw one last week. That's the first overt cusp fracture on a Ribond MOD that I've seen in I think forever. They will crack, but I've seen composites. I've seen porcelain crack. I've seen Emax crack in half. People can split teeth if they do the right thing in the wrong way, or the wrong thing in the wrong way with the wrong force. Everything ultimately can fail. Either the restoration fails or the tooth fails. Something can fail, and that's true of this too. The composite is only as strong as the composite, and but to do the ceramic, depending on the ceramic you're using, depending on how much you're damaging the tooth to get that, I think the net effect might be more damage with the indirect. That being said, if you somebody who favors the indirect approach, try to preserve the biorim, do IDS, indirect sealing, manage the bond, and if you manage all of that, then you're going to have a good restoration. It's going to be more invasive than what I'm doing, but it has other advantages. So I think there's I don't think it's I don't think it's something where one or the other can say that's terrible dentistry. If it's done well, they're both really great restorations. And I think it just sort of at that point really depends on your skill set. This is very much dentist centered as far as fussing with your hands and doing these little things and taking the time. The onlay type restoration is partly managed either by the milling machine or the lab, and you have to have meticulous bonding technique. So, you know, they're not the same, but I would never criticize somebody for doing an onlay on that tooth, for example.
Okay.
Now, if somebody took that tooth and did a root canal in the crown just cause, that I'd criticize because it doesn't need a root canal, right? So I think if, you know, if those biomimetic principles are being followed, then, you know, you could argue that maybe the ceramic is better. Now, Pascal's stuff with ceramic is porcelain, feldspathic, his original biomimetic studies. In my experience with the feldspathic has been that eventually they crack, and that the lifespan isn't really that much better than what I do with composite. So maybe not at all. They're beautiful, they're well done, but they also can crack. So feldspathic isn't very strong.
Thank you. The follow-up question of that is was asked, in traumatic bite cases where most of the posterior teeth have visible cracks that are asymptomatic, what do you do? Treat or leave?
Say that once more, I'm sorry.
In traumatic bite cases where most of the posterior teeth have visible cracks which are asymptomatic, what do you do? Treat them or leave them?
Oh, that depends. That really depends a lot on the teeth, the patient, and the age of the patient. You know, I have a concept I like to talk to patients something about, which is getting to 90 with your teeth. And if the patient with a bunch of cracks is 85 years old, I'm going to cross my fingers and hope they're okay. You know, I'm just going to do that. But if they're 20 and they've got all that damage, then is it enamel damage? Is it adjacent to restorations? Is it the kind of damage that has been shown to often lead to cracks in the dentin? So if what we're seeing on the surface is suggestive of potential damage to the dentin, I'll recommend treating it. I have one of the 4 cases in that little collage at the end was a bicuspid that was veneered and had a mesial to distal crack line in a otherwise virgin tooth, and we prepped it out. We in fact couldn't get it out, so that was a split getting ready to form asymptomatically, and I treated it. So, and that's looking at it with 6 power and lights and seeing that it looks structural. And if something looks structural and the patient's not 85 years old, you know, I'm going to talk to the patient about it, about the risk of watching it versus not. If we're watching it, what are we watching it for? For it to split? So, you know, so it's problematic. Watching is not effective. It's effective for maybe pre-decay interproximally, you know, enamel decalcification. We can try to remineralize and we can watch that. We can try to repair it, get it to repair. But with cracks, there's no opportunity there. If the risk is there, at some point you just have the magic bite and you break your tooth. So I do selectively try to diagnose, is it structural or not? If it's superficial, I don't care. If it looks structural, we have a conversation.
Okay.
Yeah, it's a good question.
Another person asked a very nice question. They said, would doing rib-on restorations after a root canal avoid the need of crowns for patients who can't afford them?
Absolutely often does. It depends on the diagnosis. Again, but yes, I know Ali is doing the same. We have some interesting work that we've done with core buildups, and there are no posts, no pins, no posts ever. That's consistent with Pascal. But we're doing it with fiber. I'll be talking about that at the next webinar, and it results in. So we did a study with no ferrule, almost the same study that Pascal did with indirects. We did it with no ferrule using fiber, and got some stunningly good results with that. And I actually had an email exchange with Pascal about trying to make our type of study, our technique, fit his protocol so that we can merge the data, but he's moved on to other things. So he kind of forwarded the stuff to the people that co-authored his studies, and we'll see what happens. But yes, if the tooth is structurally intact, I'm not going to, crowning it isn't going to provide, it doesn't appear is going to provide better support than doing the fiber buildup. And that's, still, if there's enough tooth structure, enough sound tooth structure, everything's going to work pretty well. So if it was a carious endo, I think the odds of success with the fiber are excellent. And when you do the crown on those teeth, you're taking away peripheral tooth structure. So I'd rather not do that. I'd rather either do like a Pascal or Graham style biorim preserving onlay, or do the direct fiber. And in my case, I'm going to do the direct fiber. Graham would do the onlay. Pascal, who is one of the best in the world, would do the onlay perhaps. And I can't say that's wrong at all, but I would do the fiber.
Okay. I'll just ask a couple more questions here before we wind down. Another question came in saying, if you need to remove the rib bond or fiber reinforced composite, is it difficult?
No, it's easy. Yeah, easy to do. It's just white stuff. It comes out.
Another question is, how long do you typically take to do your biomimetic reconstructions, the direct ones?
Separating out the most incredibly hard ones, it's 1 to 2 hours, usually an hour to an hour and a half. And the easy ones are quick. If it's not a large old restoration, large old filling, and I'm going to put the fiber because there's room, that doesn't take me too much longer. Maybe, the issue that takes longer is doing the proximal wall first, and I do that anyways. So it's 10 minutes if it's a simple tooth. If it's something like this, it takes longer.
And just finish up this last question. How do you trace down your cracks? I know you mentioned a few things before about different shapes of burrs, but using between the burrs, ultrasonic instruments, and air abrasion, et cetera, how do you trace down your cracks?
From what we saw with ultrasonics, I would not even consider touching that with an ultrasonic. So we didn't do ultrasonics in the crack study, but we did use an ultrasonic knife to try to create cracks to do the study on, because these were uncracked, extracted teeth. And the ultrasonic knife wreaked havoc on the tooth. It was terrible. I mean, just terrible. So I would not be playing with ultrasonics on dentin. I think it's I'd love to try that in the lab with Ali and the OCT, but I think it's really probably not a good idea. I try not to use burrs now. I am using them on the line angles, but I'm using the AquaCare on the dentin cracks, on the vertical pulpal floor cracks. And the question then is how far to go, and we'll cover that a little more at the next webinar. But that's also currently an unresolved question. You don't want to expose the pulp, and I've had conversations with Dwayne Arola and with Vitsap Kravari about this. Ali as well with me, and actually different opinions from the two of them. One is focused on critical crack length. One is focused on not disrupting. So I think it's better to make the crack less deep if you can't get it out. First of all, if you don't know if you can get it out until you try. So I think it makes sense to try. Dwayne Arola agrees with that, who's really kind of a structural expert. And then but then there's a point to stop. And I think David Alleman's guidelines help with that, where to stop. It's that's averaging out age. You can look at the radiograph, but how far do you go before you stop trying, because you don't want to expose the pulp, and then you span with ribond. So I want to try to get the crack out without propagating it, and where this information starts to divert from David's Alleman's is the burr can cause damage. And we saw that consistently in the study, and that's not something anyone has ever done before. So we have new information telling us that what we knew in other ways, burrs cause vibration, and the vibration and the stress caused by drilling on teeth can cause damage. So we want to be careful. And the best way to be careful is to do those with air abrasion. And we still, I think, need to look at bonding with water air abrasion versus air abrasion. And I have a feeling that the dry air abrasion with particles may wreak havoc on the hybrid layer in the dentin and make bonding more complicated. I don't know. That's something that that we have to talk about and look at. I've looked at studies and I've not found anything, only one study really looking at much better bond strength with air abrasion, but it's not clear what they were using. So I'm not sure yet. I am sure that air abrasion on cracks isn't going to grow the cracks. I'm pretty sure that ultrasonics are bad, but we haven't tested it, and except for the knife. And I know that burrs, the coarser the burr and air turbine handpieces are going to be really bad as well.
All right, well, thank you. I mean, we've definitely had a full lecture, full of question answer session. You went over time. I really appreciate everything, Grant. You've been amazing, and we're all excited for 2 weeks from now. So please, everyone on this call, please mark your calendars. 2 weeks from now, we will have another webinar. If you type in ABD10, you will get $10 off that webinar. But for today, please become members of the ABD if you have not already done so. One of the best investments you can ever make. And we also look forward to Dr. Ali Reza Sadar's lecture coming up as well. So please stay tuned, mark your calendars for 2 weeks. It's gonna be more great information, and thank you again.